Hey everyone, my name is Timur. I'm a medical student from Berlin, Germany, and I would like to talk to you about ischemic heart disease, which is a very high-yield topic for both step 1 and step 2 CK. In this video, I would actually like to combine the preclinical aspects of ischemic heart disease with some clinical presentations because this is actually the way NBME starts to test these concepts. So I would like to talk to you about normal anatomy and physiology of the heart blood supply, but at the same time, we will talk about the common clinical presentations of the ischemic heart disease, about major risk factors, and at the end of the video, we will tackle the big boss of the coronary artery disease, myocardial infarction. We will also go over some step-like questions about this topic. So let's jump right into it. Ischemic heart disease is a very broad topic of discussion, and the problem we have in this clinical scenario and this clinical problem is the coronary artery disease. Coronary arteries are the arteries that supply the heart muscle myocytes with oxygen and macro and micronutrients. Basically, we need blood supply for our heart. That makes sense, but unfortunately there is some inflammatory and degenerative process in these arteries, which results in diminished blood supply of the heart cells. At the same time, the presentation of ischemic heart disease might actually vary, and the factor that determines the symptoms a person might get is the lumen narrowing. Actually, most patients with ischemic heart disease don't experience any issues at all. They are symptomatic, but if the vessel is narrowed, the degree of the vessel narrowing is between 70 and 90%. There are first typical symptoms, which are called stable angina. We will talk about the clinical presentation of stable angina in a couple of minutes. If there is some greater degree of the vessel occlusion, patient will get myocardial infarction. There are multiple forms of myocardial infarction, and we will talk about the differences in a couple of slides. For our purposes here, we've got unstable angina and anSTEMI, where there is still some blood flow through the vessel, and then we've got the STEMI, which is the big boss, as I said. So this is the classical myocardial infarction we usually think about when we talk about that. At the same time, I would really like you to think about myocardial infarction as a supply and demand problem. Here is a typical picture, pathophysiological picture of atherosclerosis. We see atherosclerotic plaque. So here is the, I really hope you see me writing. Here is the endothelium, and endothelium is actually the first layer of the blood vessel that is getting damaged through atherosclerotic process. This results in an inflammatory process with the recruitment of macrophages, which will come in and consume that endothelial cells, some lipids, and they will form the so-called foam cells, which is a very well-known term for atherosclerosis. You can Google a picture and look at them. Then it will result into the smooth muscle proliferation and further inflammatory processes with fibrosis and plaque formation, smooth muscle proliferation and migration, and at the end of the day, that will result into the vessel narrowing. So there will be diminished blood supply. But the oxygen demand might remain unchanged. And at this point, I would like you to think about the similar clinical presentations. Those are vascular claudication. You've got some vessel narrowing in your legs. A patient walks a couple of blocks or a couple of minutes, I don't know, then they experience leg pain because there is higher oxygen demand. There is chronic chronic abdominal ischemia, chronic mesenteric ischemia, you don't have issues at rest, but then you consume some food, you eat, and you have to transport all the micronutrients throughout your body, and then you get some serious tummy ache because you've got an issue with your mesenteric vessels. So now let's focus on the ischemic heart disease, on coronary artery disease, and as I said, there are multiple forms of this phenomenon. First of all, let's talk about typical presentation, typical inguinal chest pain. For a patient to have a typical chest pain, they have to have all the three criteria I've listed on the slide. Loss of substernal chest pain, so this is the pain usually located in the middle of the chest, behind your sternum. The pain will usually be worse with exertion and stress, and at this point you should actually understand why, because you will increase the demand under these conditions, and this pain will get better at rest because you will actually lower the oxygen demand in your heart muscle. If there is two or less criteria fulfilled, we will be talking about atypical chest pain. That's not important for our purposes here, but it will be very important for conducting primary diagnostics. And in the next video, we will talk about the phenomenon called pretest probability. That should make sense to you that patients with atypical chest pain will have a lower pretest probability for having myocardial infarction or a stable angina. But now let's focus on a patient who has these typical symptoms. First of all, we've got stable angina. Stable angina is a demand problem. These patients do have a vessel narrowing, so they have a supply problem. But the supply is reduced at baseline. Then they experience some physical or emotional stress. They increase their oxygen demand, and this is the demand problem. Then we've got unstable angina. Unstable angina is a supply problem because demand is unchanged at baseline, usually. I've listed some features that would suggest unstable angina, and one of them is typical inguinal chest pain at rest. That's what I'm talking about. So you're resting on your couch, you don't experience any increase in oxygen demand, but you still get chest pain because the vessel is so narrowed you cannot supply your heart vessel even at rest. You should also think about this is a clinically relevant point. You should consider any first onset angina as possibly unstable, and you should make the whole workup for possible myocardial infarction in a patient presenting with typical inguinal chest pain for the first time, because that actually might be in myocardial infarction. We've already said that most patients are asymptomatic, and that might be the manifestation of the first symptoms, myocardial infarction. We can also think about unstable angina as anginal exacerbation. We all know about COPD or asthma exacerbation. This is kind of similar. You just have untypically severe symptoms in a patient with a past medical history of coronary artery disease. Now let's talk about possible risk factors for this condition. Those can be modifiable and non-modifiable. The more important ones are obviously the modifiable risks. And please, just remember that that's very important. It's getting tested everywhere all the time. Smoking is the single one most important cardiovascular risk factor for coronary artery disease. There are many pathways through which smoking can be dangerous for blood vessels. But this is the single most important risk factor. Just remember that it's getting tested all the time. You will see it on all CMS forms, on all shelf exams. It's a very high yield topic. Other things I consider to be very important, and which are actually considered to be important by all the specialists, are diabetes, because diabetes is actually considered to be a so-called coronary artery disease equivalent for the risk of myocardial infarction, and we will talk about that in the second video. But those patients are in insanely high risk for myocardial infarction, and also the patients with end-stage renal disease. Cardiovascular mortality is actually morbidity and mortality is actually the most common cause of death in patients with end-stage renal failure. For our purposes here, high blood lipids, okay, high LDL, low HDL is considered to be bad, but you all know that there is actually a big discussion in the scientific community right now, because it doesn't seem to be that simple. But for our purposes here, we'll stay by that. Arterial hypertension is important as well, but it's not as important as smoking. Just one more time, smoking is it's the worst thing you can do for your heart and vessel health, and probably one of the worst things you can do with your body in general. Please don't smoke. Just remember that. I kind of mark BMI and non-active lifestyle. Of course, that's important, but there is actually only low evidence showing that this is a significant factor for coronary artery disease and myocardial infarction. So it's if you have a board question asking you about modifiable risk factors, this is probably not the right answer. You should pick smoking. If smoking is not available, it's probably diabetes. Those are non-modifiable risk factors, which kind of makes sense. So age, the older person gets, the higher is the risk for myocardial infarction. Family history, not any family history, obviously. So only if you've got a first-degree relevant, a male relative over 65 years old, or a female first-degree relative over 55 years old with myocardial infarction, that's significant. Male gender and postmenopausal females are at higher risk, and African American patients are also the higher risk for myocardial infarction. This is a very high yield topic. Please make sure you understand that. Now let's talk about some basics before we discuss myocardial infarction. So this is a picture you can see in any internal medicine or anatomy book. This is the coronary circulation of the heart. Most people have a so-called intermediate coronary type. That means that the left circulation and the right circulation are kind of the same. That's not very high yield for the board exams. I don't see this concept tested really often, but there are some patients that have a more prominent left-sided circulation or right-sided one, and the difference is actually the artery that gives origin to the PDA, posterior descending artery, which supplies the posterior portion of the heart with blood. But as I said, that's not really relevant for our purposes here. Let's concentrate on the highest yield arteries. Let's just discuss them. So the first one is basically the left-sided circulation, LAD, left anterior descending. Here's the artery I'm pointing it out here. It supplies the anterior and apical portions of the heart and the anterior third of the septum, and this is the most common vessel to get occluded. It will actually may result in some really important consequences, but we'll discuss them a little bit later. Then we've got the LCX, the circumflex artery that supplies the lateral portion of the heart, and then we've got the right-sided circulation with PDA, which actually supplies not only the posterior and inferior portions of the heart, but also the SA and AV node. So those are obviously very important structures for the conductivity in the heart. And if you've got a right side infarction, you might actually end up having a patient with a low blood pressure. Here's the this is the classic formula for blood pressure. Obviously, they will have a low cardiac output, but at the same time, there won't be only hypotensive. They will be bradycardic as well because the SA node won't work properly. And those are the patients. They are supposed to get fluids. They are not supposed to get nitroglycerin because the right circulation cannot work properly. We will talk about that in more detail in the next video, but please don't give nitroglycerin to a patient with an established right-sided infarction with clinical constellation I've mentioned before. They are supposed to get fluids. This is very untypical for any sort of cardiac disturbance, but this is actually an exception. We've already started to talk about blood pressure. And blood pressure is a product of cardiac output and systemic vascular resistance. The higher systemic vascular resistance, the lower cardiac output is because it has to work against all these narrowed vessels. Those are actually all the factors that will determine both cardiac output and blood pressure. I've already mentioned vasoconstriction, which result in higher systemic vascular resistance. This is what we call afterload. Then I've already mentioned giving fluids to a patient. This means making preload higher, which is atypical because we will actually want preload to be lower. I will mention that a little bit later. And then we've got obviously heart rate and contractility. All these factors determine the oxygen demand, the oxygen consumption of the heart, which we've already discussed. And those are all the pharmacologic goals we use in a patient with chest pain, with cardiogenic chest pain. What are the meds we could use to decrease these parameters? Let's start with preload. Basically, we'll give nitroglycerin. In a classical myocardial infarction, the patients will get nitroglycerin. It will result in venous, that's very important, venous vasodilation, which will lower the preload because all the blood will stay in the venous system. The heart won't have to pump that much blood. That's very important. Then we've got afterload. What can we use to decrease afterload? Actually, there are multiple meds we can use to do that. One of the common ones are ACE inhibitors and ARBs, and also calcium channel blockers. We will discuss all these drug classes in another video. For purposes here, that's actually enough. And then we've got heart rate and contractility. And that's where we use beta blockers, beta-1 blockers, because we've got beta-1 receptors in our in the heart, and beta blockers such as labetalol or atenolol. They can be used to decrease heart rate and contractility. Okay. The last point I would like to discuss is the mitral valve, which has got a bit more complex blood supply. It consists of anterior and posterior leaflet with anterior and posterior papillary muscle, which are connected to the leaflet through chordae tendineae. And the anterior blood supply is actually dual from LCX and LED, so it's not that bad if one of these arteries gets occluded. In the posterior artery, there is an increased rupture risk because there is only a supply throughout RCA, and that sort of occlusion might result in acute mitral regurgitation, and we will talk about in a minute. So Now let's talk about myocardial infarction. There are multiple mechanisms that might result in a myocardial infarction. Those are plaque rupture, which might occlude the vessel as it is, but it also might release some thrombogenic substances with primary and secondary coagulation, with thrombus formation, with some hemorrhage, and that will result in the infarction of the heart muscle, which can be reversible or irreversible. In a patient with unstable angina or NSTEMI, the occlusion will be incomplete. STEMI is a complete occlusion. That's very important. So imagine we've got sorry, we've got our heart cavity. So that would be pericardium, that would be myocardium with myocytes, and this is the endocardium. The zone that is most prone to ischemia is the subendothelial myocardium, because just think about that. You've got the distal portions of myocardium. Here are all the blood vessels, coronary arteries, so the blood supply is kind of straightforward, and actually it can actually diffuse even if one of the arteries gets occluded. And then you've got the endocardium, which is supplied by the blood from the heart cavity. That is pretty straightforward as well. Subendothelial endocardium doesn't have that privilege. It is very prone to infarction. This is the first portion to get infarcted. This is why this is where you see a so-called ST depression. It's not the topic of today's discussion. It is the portion of the diagnostic part of the presentation, but you'll see firstly an ST depression, and if it gets occluded completely, you will get a transmural infarction, which will result in a STEMI, ST elevation myocardial infarction. This is an important concept. It's important for you to understand that as well, and we will talk about that in the second video with some ECG examples. For purposes here, just remember that. So occlusion might be complete or incomplete. Now we are talking about the complete occlusion, classical myocardial infarction, and there is a number of changes which are possible here. And let me tell you this, I cannot stress it enough. It's very, very important for you to understand your basic pathology. You should just know the principles on inflammation. What sort of inflammation do we have here? Which sorts of inflammation are there? Of cell death. Let's talk about cell death. There is apoptosis and necrosis. In this case, we've got a case of necrosis, which makes sense because there are two reasons which might cause profound or not profound necrosis of a human cell. Those are, firstly, infection, and the second one is basically massive ischemia. So in this case, we are dealing with massive necrotic process, and which will cause acute inflammation. What are the cells that are involved in acute inflammatory process? Those are primarily neutrophils, and those are the first inflammatory cells to appear in the heart muscle. This is the process, so acute inflammation cannot just continue as long as the neutrophil wants that. This is why we've got the macrophages, which are basically the managers of inflammation. This is actually a term from Dr. Sattar's Pathoma. I can highly recommend you going through his lectures and his book. Those are the managers of inflammation. They will control the inflammation. They will stop the inflammatory process. They will start the reconstruction, the regeneratory processes in the heart muscle. which will result into healing with fibroblast activity and scar formation. So now let's go through this timeline one by one. First of all, in the first 4 hours, we won't see either microscopic or macroscopic changes. That's very important. So this is actually reversible. So a heart cell and myocyte has got enough energy, enough oxygen to avoid some sort of irreversible change. But there are some very nasty complications you might get at this point due to the disruption of the metabolic and electrical processes in the heart muscle. The most important one is SCD, which is a sudden cardiac death, which is the most important cause of death in patients with acute myocardial infarction. You can get ventricular tachycardia, ventricular fibrillation. Those are all very emergent processes. And this is actually arrhythmia is a very important cause of death in the patients in the first couple of hours. So many patients, some patients won't even make it into the hospital because they will experience sudden cardiac death. Another factor is another possible complication is acute heart failure or cardiogenic shock, which should make sense to you. The first changes we might see in the heart muscle will appear after about 4 or 5 hours after the onset of the ischemia of acute ischemic process. And what we see is a coagulative necrosis. I've already mentioned that this is a necrotic process. What is the hallmark of necrosis? Right, the loss of the nucleus. The nucleus will actually will actually start shrinking, and then there will be a complete lysis of the nucleus, nucleolysis basically. And macroscopically, you will see some dark mottling, which is kind of typical for coagulative necrotic process. Then you've got neutrophilic infiltration that will result in a yellow pallor with complication of fibrinous pericarditis. I will talk about it in a couple of minutes. Then we've got the macrophage infiltration in the next couple of days. And this is actually the stage where we get one of the nastiest complications. Let's go through them one by one. Free wall rupture might result in pulseless electrical activity, which is kind of similar to SCD presentation for the first couple of hours. Many patients won't make it through reanimation, through the code, will basically die or experience some severe hemopericardium with obstructive cardiac shock. Then we've got acute mitral regurgitation. I've already mentioned that. You've got the posterior leaflet destruction with acute cardiogenic pulmonary edema with other symptoms of left ventricular and atrial dysfunction. Then we've got the interventricular septum rupture, which will result in the VSD, ventricular septal defect, with a characteristic holosystolic murmur at the left sternal border. And then we've got the pseudoaneurysm. Let me talk about that. So this is called pseudoaneurysm because you've actually only got scar tissue protruding through the heart, so there is no real muscle here, and the danger is rupture because, as I said, there's no real heart muscle here. So that this is the nastiest part about that. And the last part, weeks to months, you might get a true aneurysm, which contain all the parts of the heart, including the myocardium and other layers, and the blood flow will be turbulent in this part. This means basically irregular. And one thing you should be afraid of is thrombus formation. It's kind of similar to AFib rib, in the left atrial appendage, but in this case, this is just the post-myocardic true aneurysm. Now let's talk about differences between fibrinous pericarditis and Dressler syndrome. Very important point. Dressler syndrome is basically an autoimmune process because there is a severe disruption of myocardial immune system, basically because this is kind of privileged immune organ, and you normally don't see that much of infiltration in the heart muscle. So you've got a T cell mediated process, which will result in acute pericarditis with pericardial rubbing, pleuritic chest pain, and some sort of cardiac tamponade. In the case of fibrinous pericarditis, the pathophys is completely different. It's just the basic acute inflammatory process that will result in the fibrinous accumulation in the pericardial sac that will basically disrupt the mechanic of the pericardial heart layer, and will result in the kind of similar presentation, but the time frame is the most distinguishing part between these two conditions. There are also some other differences. Fibrinous pericarditis might actually be a result of some other processes in the heart as well, but for our purposes here, we will concentrate on myocardial infarction, and the time frame is the most important factor here. The treatment is kind of similar. Those are both more or less immunologic phenomena. So you basically get, the patient basically gets NSAIDs and colchicine and calls it a day. So we hope the patient gets better. But this is an important concept that commonly gets tested on shelf exams and board exams. Now let's go through a couple of clinical vignettes. Those have been created by ChatGPT. I just wanted the ChatGPT to come up with some clinical stamps. So the first question: a 58-year-old male patient with a past medical history of hypertension, dyslipidemia, presents to the emergency department with severe chest pain radiating to his left arm and diaphoresis. Is diagnosed with an acute myocardial infarction. As you counsel the patient his condition and risk factors, which of the following factors should be emphasized as a significant contributor to his MI presentation? Let me tell you once again, this is smoking status. It's the most important cardiovascular risk. I cannot stress it enough. It's not alcohol consumption. It's not sedentary lifestyle. High fiber diet is actually quite okay. A familial history of MI is important, but not as important as smoking cessation. Now let's continue with the next question. A 55-year-old female presents to her primary care physician with complaints of chest pain, shortness of breath, blah blah blah. So we've got stable angina. We make a stress test. We'll talk about that later. So there are some signs of stable angina. Which sort of disease is that? I've already talked about that. This is a stable angina. We've got Prince-Metals angina and variant angina. I wanted to mention them in the next video, but just let me tell you that there is some sort of heart vessel spasm in this disease, which is actually not permanent, but it can be precipitated by cocaine or methamphetamine use, or through smoking. Smokers are kind of famous for getting this condition. So there is paroxysmal coronary artery spasm, and you just give these patients some calcium channel blocker such as amlodipine, so dehydropyridine calcium channel blockers to elicit the relaxation of the coronary artery. Those are basically non-right options. Silent myocardial ischemia, I've already mentioned that. Many patients are asymptomatic. These are stable angina because we've got ST segment depression with typical anginal symptoms, but we'll talk about diagnosis and differential in some other video. Now, the last question. So we've got a 50-year-old male patient with myocardial infarction. He gets some, this is a bad stem or a bad hospital. I don't know, not the best one. He gets TPA. We will talk about different treatment modalities of myocardial infarction in the next video as well. There are basically two options. You basically time to needle. You get TPA similar to acute ischemic stroke treatment, or you get a stent, which is a preferred method, but we'll talk about that in another video. He gets some sort of, I don't know, some sort of therapy, some sort of treatment. And then 24 hours later, his condition deteriorates and he's got a harsh holosystolic murmur best heard at the apex. This is actually a gimmick, so a very simple question. What are we thinking about in a patient getting a holosystolic murmur best heard at the apex? Lateral regurgitation. So the answer would be papillary muscle rupture, which will result in mitral regurgitation. So this is the right answer for this stem. What is the most likely complication responsible for these new findings? So we've already answered that. Ventricular aneurysm. It wouldn't correspond with the timeline we've got here. 24 hours later, we've talked about that. Ventricular aneurysm would take months to form. That makes sense to you. That should make sense to you because you have to generate a lot of heart muscle to build something like that. That can be couldn't be the right option. Then we've got acute pericarditis. This is actually that wouldn't correspond with the clinical picture. Those patients usually have pleuritic chest pain, so pain on chief inspiration or inspiration, which will so that has nothing to do with this presentation. It's not something we would consider. It's not left ventricular free wall rupture. That will generally be a much more acute presentation, and ventricular septal rupture will actually result in new holosystolic murmur, but it won't be best heard at the apex. You would have to auscultate the left sternal border to find this sort of pathology. And this question actually concludes my first video on myocardial infarction. I really hope it was useful for you. And please leave your comments, give this video a like, my channel a follow. Thank you very much, and I wish you a nice day. Bye.